It's 6 o'clock, so we will go ahead and get started. I want to thank all of you for coming to tonight's CME, Shifting Landscape of CDH Treatment and Outcomes. A couple of housekeeping items. If you have questions, please put it in the chat box and we will go ahead and answer those the last 10 minutes of the program, or perhaps during, if that works out. And we will also have the opportunity for you to raise your hand at the bottom of the screen virtually, and we can unmute you if you would like to ask your question that way. Also, we will be putting an evaluation in towards the end of the presentation, and it only takes a couple minutes to fill out. So if you could so kindly do that, we rely on feedback to continue to improve our education opportunities. So I will now introduce our two speakers tonight. The first is Dr. Stark. She is the director of the Congenital Diaphragmatic Hernia Program, and she's also the co-director of Maternal Fetal Intervention and Surgery Program. She went to medical school at St. George University School of Medicine in West Indies. Her residency was done at Harbor UCLA Medical Center. Her fellowship done at Seattle Children's. She has board certification in both general surgery and pediatric surgery, and Seattle Children's has had her on staff since 2018. One of her research interests is improving CDH outcomes using novel treatment strategies and a multidisciplinary team approach. Our next presenter is Dr. Billy Moria, and she is our medical director of our NICU. She went to medical school at Bharati Vidyapeeth Medical College in Pune, Maharashtra. She did a residency at Children's Hospital of Michigan and her fellowship at Baylor College of Medicine. She's board certified in both pediatrics and neonatal perinatal medicine, and we've had her on staff since 2015. And her clinical interest is providing equitable and empathetic care for critically ill, high-risk newborns as part of a multidisciplinary team. So without further ado, I will go ahead and pass this on to our presenters.
Good evening, everyone. Thanks for joining us this evening. We're both very excited to be here and to talk to you about congenital diaphragmatic hernia. So I just go through our objectives really quickly so you can know what to expect. We'll start with a very brief overview of congenital diaphragmatic hernia, and then we'll look at past and current CDH outcomes and the differences in outcomes between high volume and low volume centers. And we'll specifically focus on outcomes in each of the categories of CDH, meaning mild, moderate, or severe disease. And then we'll look at how we've changed our treatment paradigms in order to try to achieve higher outcomes. And some of the things that we have changed have been how we interpret prenatal assessments and development of a multidisciplinary CDH program with dedicated providers for continuity and expertise. And we've also standardized treatment for these babies and adopted innovative treatment strategies early.
Our goal really is to share with you how the care of this disease process has evolved over time, how we collaborate with medical teams in different phases of a CDH patient and their families' lives, namely prenatal phase, the immediate postnatal hospitalization and outpatient care, and how we individualize treatment plans in keeping with the family's goals and values.
And so I'll just start with a brief overview. I know many of you on this WebEx know a lot about this disease already, but it's a rare disease. It happens about 1 in 4,000 births. It's diagnosed prenatally now the majority of the time, so about 70% of the time, and it's usually diagnosed in the 20 to 24 week time period. Overall, national mortality rates are still high, so around 30%, and it's a very complex disease with high acuity and very high resource utilization. But the upside to all of that is that the survivors have a very high quality of life. It's a highly variable disease, so there is a full spectrum of clinical presentations from intrauterine demise to early postnatal death from lethal pulmonary hypoplasia to even an incidental finding on a chest x-ray for a URI in a toddler. And because of that, survival is also quite variable, almost to the degree that there are different diseases, between a mild and moderate baby. And so we try to put a lot of effort into categorizing these babies prenatally. And I wanted to just put up here some of the published rates of survival from approximately a decade ago. And I'll just point out here, but we'll talk a lot about it later on, that um, the survival rates for mild disease hasn't changed, right? Already you're at 100% survival if you have mild CDH, but there's been really substantial improvements in the moderate and severe categories. And with the addition of additional information, we're really able to risk stratify these babies in a more nuanced fashion, which obviously helps parents for counseling prenatally, but helps us on the clinical side as well. And so it's a complicated disease because it has lots of different components that are all at work. And the challenge in treating this is due to the interplay between all of these things. Obviously, there's a diaphragmatic defect, so a hole in the diaphragm, and that's the mechanical part of this disease, but it's actually like the less interesting and less important part of the physiology. So the physiology itself is what makes the babies so sick. And I'll just kind of go through them briefly, but in terms of the pulmonary hypoplasia, this really manifests as the inability to do normal gas exchange. Pulmonary hypertension affects gas exchange, but it leads to severe cardiac dysfunction. Pulmonary maldevelopment really speaks to the anatomic differences at the level of the capillary alveolar complexes in these babies, and it affects gas exchange. But even more importantly, it really affects future chronic lung disease states, which the most severe cohort of these babies goes on to develop. And then cardiac dysfunction is a big part of the disease, and more recently, research has really surrounded different cardiac states and how cardiac dysfunction can contribute to the overall morbidity of the disease. And so we commonly think about right heart failure because of pulmonary hypertension, but there are different variations of left heart failure, including left ventricular diastolic dysfunction, that really can make the disease state worse and contribute to the overall clinical picture. This is a nice schematic that kind of integrates all of the things that I just talked about. So there's pulmonary parenchymal disease, pulmonary vascular disease, and then oftentimes pretty severe cardiac disease. And this is why in the past outcomes have been so dismal. And this is, I thought, an interesting paper that came out about 20 years ago. And the title really captures kind of the pervasive feeling of the time when survival was at best 40%. So this is a study out of the UK, and it really mirrored what was happening in the United States at the same time. And despite all of these interventions that were made over this decade from 1991 to 2000, there really wasn't a big shift in overall mortality. And survival was, as I kind of mentioned, 40%, which is pretty dismal. And so they really were proponents of the fact that, this is a terrible disease and more than half of the babies are going to die. And at that time, that was really what people thought about this disease. But thankfully, outcomes have improved. ECMO is more readily available and it's much safer. Our ICU care is much better. We have newer treatments for pulmonary hypertension and much better lung protective ventilation strategies. Also, when this was written, only about 50% of babies were diagnosed prenatally, and that often would lead to the birth of a baby with a life-threatening condition in an unprepared hospital setting. And now, as you know, the majority of cases are picked up prenatally, and delivery can then happen in a tertiary or quaternary center.
And like any other disease process, advancements in the field over time have resulted in improved outcomes compared to historical cohorts. And as always, there remains morbidity and mortality, as there are many aspects of this disease process, such as the underlying genetic syndromes, cardiac dysfunction that we're still learning quite a bit about, and how to manage it. And we are still learning about each of these things each day. However, we have come quite a long way from where this paper has put us in how to manage these patients and improve their outcomes on a day-to-day basis.
So this kind of shows the current overall survival. And so this was from a nice review that came out in 2017 that showed overall survival, national survival, about 70%, which means 30% more, there's still a 30% mortality rate. But as we'll kind of highlight later on, this mortality is almost always in the babies with the most severe disease. And it gives a nice breakdown of survival in babies who need ECMO versus don't need ECMO. And then this is a paper that these are survival rates from the CDH study group, which I'll talk about later, but is a national registry that kind of is able to look at thousands and thousands of CDH babies over the country and internationally and cohort this data. And so this is a representation of defect size and survivability. And so just the thing to know is that this survival data obviously applies only to babies who made it to the operating room. And so the babies that were the most severe and maybe were not able to make it to surgery are not included in this. And then just that what makes sense and what people know already is that defect size severity correlates with clinical disease severity. This is a nice representation from a paper that came out last year, and outcomes really vary by center. And this graph shows this graph includes about 102 centers and over 10,000 patients. And they basically looked at low and high volume centers. So high volume centers being those that have more than 10 CDH babies a year, and low volume centers being less than that. And then also ECMO usage. And basically what this bubble graph shows is that at a high volume center, if you're in the most severe cohort, your survivability is much higher than if you are born at a low volume center where there is infrequent ECMO use. And so volume really does actually matter in terms of how you care for these babies. We are a high volume center, and our volume has only increased over the past 5 years since establishing a multidisciplinary program. This graph does not include babies that were postnatally diagnosed, so there are more babies than this that we get, and I'll explain that a little bit later. But these are all babies that get referred to us and have a prenatal diagnosis. And our overall survival with a prenatal diagnosis is around 85%. It varies a little bit from year to year, but that's the 5-year average. And then all comers, which includes babies that are diagnosed postnatally, is about 90%. And I'll just show our trend over time. Again, this excludes babies that don't have a prenatal diagnosis. So these are babies that are referred to our prenatal center, born at UW, and then transferred to Seattle Children's. And our survival rate is consistently better than the national average. It does vary by year. And then that's why we average our survival over several years. So because outcomes are so heavily based on disease severity, we have lots of strategies that have been employed to try to improve the accuracy of our prediction models. And so we do it prenatally and postnatally. Prenatally, we use it to counsel families, inform decision-making. We try to determine the modality and timing of delivery based on disease severity, and we make sure life-saving resources are available. And really, we think all of this optimizes outcomes.
And prenatal markers we recognize are by no means perfect, but they do offer a best educated guess. And this is what we have to go on to help inform us as a team and the family for what the potential best or worst case scenarios can look like.
And so the two imaging modalities that I'm sure most people are familiar with are ultrasound and fetal MRI. And ultrasound is what has historically been used for predicting outcomes. And the measurement historically used was the lung to head ratio. O to E LHR is the other way of reporting it, and it's nice because we can do it across all gestational ages because it's age adjusted to cohorts. And this is what is used at major fetal centers for deciding whether or not a baby is a fetus is a fetal candidate. And it's probably the most widely used ultrasound measurement. Here you can see survival rates, and more commonly, babies are being broken down into 4 categories as opposed to 3 categories. So mild, moderate, severe, and very severe, or some people call it extreme CDH. And that's because the survivability in the mild, moderate, and severe categories has has improved over time, and having a more severe category that really captures a lot of the mortality is helpful in prenatal counseling. As everyone knows on this WebEx, liver position also, it factors into prognosis. But over the past 5 to 10 years, fetal MRIs for CDH risk assessment have been standard and now are routinely performed. Usually we are performing them at the time of diagnosis and then in the third trimester. It's really an invaluable tool for prenatal counseling because it makes very specific and reliable predictions about outcomes. And so we use this in conjunction with the ODE LHR, and it really helps with predictions. As you can see that within the fetal MRI categories, there are also 4 categories now, and we have moved to using 4 categories for our prenatal counseling as well. I think this is just an important slide for like the big take-home message is that all of these things are associated with poor prognosis, and most of this is based on lung volume. So obviously in that most severe and severe cohort, you're going to have the majority of the mortality. But then also with liver herniation, with a right-sided CDH, with left ventricular hypoplasia, those are worse prognostic markers. And then the big thing is that what more recently studies have really noticed, other centers have noticed as well as our own, is that having a genetic anomaly really portends a worse prognosis. And so this is just a snapshot of outcomes at our institution for the past 3 years. And I think it's interesting for just 2 reasons. One, it's because this is based on the earliest documented LHR, and often that's done by our referring providers, many people in this audience. And second, because it demonstrates that kind of regardless of defect size, having a severe genetic anomaly is associated with non-survival. And most of these genetic anomalies are actually discovered postnatally. So all of these babies in this more moderate category who needed ECMO and did not survive had postnatally diagnosed genetic anomalies and normal prenatal microarrays. And so it's something that we often don't know about prenatally, and ends up playing a big role in survivability long term. But even with all of this, survival in the mild, moderate, and severe category is actually quite good. And survival in the most severe category is about 30%.
And this slide essentially just depicts, real life outcomes and the challenges of prenatal prediction of outcomes. Patients that may be prenatally determined to have moderate defects may have a severe outcome postnatally and a genetic syndrome that may affect their overall health and longevity. And then patients that were prenatally determined to have severe defects may have mild to moderate outcomes and may do better than we anticipated. So what we are trying to depict here is the challenge that we have when we're trying to best guess what a patient's outcome will be when they're born.
Mm-hmm. And I just want to spend a little bit of time talking about postnatal prediction tools. And so there are several equations that look at different variables postnatally, like best gas, worst gas, vent settings, those sorts of things. And you can put them into an equation. And one of the most commonly used equations is called the Sphere equation. And it came out of Michigan. And it was widely used, and it was used nationally, and was just very recently, Michigan has stopped using it. But it was a postnatal risk assessment that I'll go into that tried to determine which babies in that severe category ultimately would survive and which babies should be offered ECMO versus not offered ECMO. So there's a study that I'm going to talk about that comes out of the CDH study group. This is a study group that includes over 90 institutions, over 1,000 patients. It was started in 1995 out of UT Houston by Pam and Kevin Lawley, and it really changed the way we do clinical research, because prior to that, almost all CDH data came out of single institution studies, and you can imagine there's lots of variability that comes out with that. So this was a way to get babies from across many different institutions, and we participate in this, and many other institutions do now, and this is almost how all of the CDH clinical outcome data gets evaluated nowadays. And so this was a study that looked at that SPHERE protocol that was from Michigan and used the CDH study group data. And basically, this is on the right side of the screen. You can see this is the SPHERE equation. And basically, it only included the most severe babies. So prenatally, if you had any of these severe prognosticators, so LHR less than 1, ODE, LHR less than 25%, or an MRI with a total fetal lung volume of less than 25%, then you were selected to be in this equation. And at delivery, ECMO would be on standby, baby would be intubated, we would do gentle ventilation, they would do some resuscitation. And within the first 2 hours, that baby needed to meet all of these criteria in order to be offered ECMO. So pH had to be greater than 7, CO2 had to be less than 100, preductal saturations greater than 80%, PO2 greater than 40. And if they didn't meet these criteria, they were not offered ECMO, and they're stratified into like comfort measures, or offered comfort measures only. So in 2017, they actually looked at this equation using the CDH study group. And what they did was they looked at all babies that qualified under this prenatal selection category, and then looked at all of the ones that, according to this equation, would not be offered ECMO, and at other institutions were offered ECMO. And in that cohort that would have only received comfort measures, 50% actually survived. And in this cohort that ECMO was offered to, 50% also survived. And so this is kind of a convoluted way of saying that in that severe cohort, we are really not great at predicting postnatally which of those babies will survive and which won't, which makes it really hard to not offer ECMO to a cohort of babies, because we actually don't know which of those babies will be a survivor and which won't. This is another paper that came out of Florida, and they looked at 172 consecutive CDH babies and basically took the worst 10% of those 172 babies, which they purported should have nearly 100% mortality. And in that cohort, they showed that actually 50% could survive with early aggressive interventions and the use of protocolized algorithms for treatment strategies. And so we don't know which babies can survive and which can't, and we do know that we can improve survival with early aggressive intervention and protocolization. And so what does survival look like in that cohort? So these are all babies with very severe disease who were treated at our institution. And this is kind of like their baby pictures on top and then their toddler pictures below, sometimes with siblings. And you can see that they have a pretty high quality of life survival. And many of these babies would not have met criteria for ECMO from that Michigan paper. And so what have we done to really try to improve outcomes for the historically worst cohort? We started with developing a program, which we were able to get actually initiated about 5 years ago. We really were focusing on building a multidisciplinary team of providers with expertise. We standardized our care, and we were really trying to commit to early adoption of novel treatment paradigms that are focused on the sickest cohort of these babies, as well as doing research to kind of support what we are initiating.
And our goal is really standardization of our practices, so trying to do it one way each time and adopting practices that have been shown to improve outcomes in our sickest cohort as we learn from other high volume centers.
So this is an overview of our program as it stands right now. You can see it spans multiple phases of care, from the prenatal part to the NICU to the floor and to long-term follow-up. And it involves a lot of experts and a lot of different providers at different steps along the way. And I actually included in here, the PICU, because now some of our babies who before really weren't surviving long-term are surviving and are sicker and end up moving up to the PICU because they graduate from our NICU. And so our program really starts at our prenatal diagnosis and treatment center, and we have a large, amazing team. We have maternal fetal medicine specialists, cardiologists, a core group of neonatologists and surgeons who see all of our CDH families, genetic counselors, fetal radiologists, etc. And because it's a diagnosis 70% of the time, we get to see a lot of the babies very early on. And the average gestational age that we see them is at around 24 weeks. And then, of course, we follow them for the duration of pregnancy. And our prenatal care is based on current national guidelines. So as they evolve, we also evolve our guidelines. And we do consults from all over, sometimes for second opinions through telehealth because we're licensed in all of these states. This is the geographic distribution of where our CDH patients and our families come from. So obviously we serve the WAMI region, but sometimes even beyond that. And this is kind of a global view, and you can maybe see that Alaska participates, and then we get little spots from all over the country. And really our volume is concentrated in the Pacific Northwest region and some parts of Montana and Idaho. And then within Washington, this is kind of where we get the majority of our babies. And so this is our core inpatient provider team. We have surgeons, pulmonologists, neonatologists, cardiologists, anesthesiologists, and all of them have helped to build this program, and all are very, very dedicated to the program and to the families that we serve. Yes, and what's not on this slide is that some of our chronic babies do end up in the PICU, and we have 2 PICU APP leads that I haven't added to our slide yet. And in addition, in the ICU, we have the normal supportive care that is there, like from dietitians, pharmacists, OTPT, nursing, ECMO specialists. And so this is a kind of a big overview of what we've changed in the last 5 years for treatment for CDH. And I think that that is what has led to better survivability and why our outcomes are better than national average outcomes. So we developed a core team of surgeons. We have a pulmonary hypertension team that is dedicated to these babies. We do multidisciplinary NICU rounds. We've started an expedited transport protocol with ECMO on standby for the sickest babies. We do early initiation of ECMO if the baby is on really high vent settings. We've switched to bivalirudin for ECMO anticoagulation. We now do early repair on ECMO for all of our babies that go on to ECMO. We do early initiation of pulmonary hypertension treatment and therapies on ECMO or off ECMO. We have a tolerance for longer ECMO runs if they're needed. We've standardized some of our pathways, and we have a multidisciplinary CDH clinic with long-term follow-up through the teenage years. And then just in the last 2 years, we've added a feeding clinic because some of the long-term issues that our patients face have to do with feeding tubes, need for occupational and speech therapy, and that's all taken care of in this clinic. And above all, we've kind of had a change in philosophy, and we have bought into trying to offer early and aggressive treatment to parents who want that for their baby, knowing that that is the best chance for a good outcome and for high survivability.
In 2021, we instituted expedited transfer for those patients that were deemed to be in the most severe category by prenatal markers. Prior to this, we used to have a handful of babies that would not survive long enough to receive potentially life-saving therapies. So now we do expedited transfer, which includes the presence of a transport team at delivery with rapid stabilization with folks from our UW team, and then transfer to Children's NICU where ECMO is available on standby. And then we continue to review and revise our expedited versus urgent transport protocols with each case and partner with our colleagues over at UW to ensure that we are meeting the needs of the patient, the teams that are caring for the patients as well.
This is just a slide that kind of shows our survival by year. But if you look at the top one, does not include any of the babies that were not well enough to transfer from the University of Washington. And so the data on the gray line actually includes those babies. And this is and in 2021, that's when we initiated an expedited transport protocol. And so now we are capturing all of those babies who before we weren't able to resuscitate or put on ECMO early enough. And part of what we changed was that we, instead of, we have a big team of surgeons here. We have 13 general surgeons. And what we really thought would make a difference was paring it down to a team of 4 surgeons. And so we have a team of 4 surgeons who do all of the CDH cases, and we have an APP and a neonatal nurse practitioner who's part of our team. We do daily rounds in the ICU and the floor. We do all of the prenatal consults with neonatologists who also have a core team in the prenatal setting. We do all of the ECMO, we do all of the surgery cases, and we do all of the long-term follow-up, and we have a call schedule to support continuity for these babies.
Over the years, our treatment paradigm has really shifted along with other centers across the country. Once upon a time, we used ECMO as a last resort for a very sick patient, and CDH repair would only occur if such a patient that was placed on ECMO was able to come off as a way to prove survivability. We have now learned from other centers, and many centers across the board have started to shift towards early ECMO strategy for the sickest patients that meet criteria based on certain gas exchange and cardiac dysfunction measurements as a way to avoid barotrauma, value trauma, and the consequences of being progressively hypoxic and acidotic over long periods of time. CDH patients needing ECMO after birth get repaired within a 24-hour period now to help with relieving compression of the hypoplastic lung and chambers of the heart that may be compressed up in the chest. Surgical repair on ECMO has become easier with the use of bivalve. Traditionally, we used to use heparin for anticoagulation, and patients that were ready to go for surgical repair would get aminocaproic acid before surgery to decrease bleeding, but that increased the risk of clotting within circuits and then required us to change out circuits. And it really made it difficult to manage the coagulation, the pro and the anticoagulation of a patient in that immediate pre and post-op period. We are now able to run a low rate of bivalve while we're in the OR for repair, while we're closely monitoring patient bleeding and circuit clotting. And over the last several years after instituting this, we've gotten pretty facile with doing that. And anecdotally, our circuits have not been really clotting as much, so our circuit change frequency has decreased, which has then decreased exposure to additional anticoagulation when you give a bolus with a new circuit, decreased exposure to new circuit plastic, and definitely decreased exposure to new blood products. We also now tolerate longer ECMO runs to allow for cardiopulmonary adaptation as best as is allowed while resting on ECMO. And this helps with improvement in pulmonary hypertension, treatment with vasodilator therapies, which come with their own risks and perhaps can be benefited by support with ECMO as those therapies are escalated. And this has allowed for us to do adequate ventilation of hypoplastic lungs with gentle settings and improved our success of coming off of ECMO.
Repair on ECMO for these babies has always been a controversial topic, but we have made an institutional change to operating within about 24 hours on ECMO. And as Dr. Bilimoria said, with judicious use of bivalirudin and some changes to our technique, we've really been able to embrace the strategy and have it be successful. It helps in a lot of ways. It gives the lung optimal space to grow and expand. The mediastinum moves back into a more central location. It makes cannula position safer for longer runs. And I think, there has been a lot of recent data that shows that this actually decreases time on ECMO, even though the babies going on to ECMO are the most severe cohort, and we're doing longer ECMO runs in general. The paper that came out in 2019, and it was also a CDH study group paper, but it basically showed better survival in babies that were repaired early on ECMO as opposed to late repair. Obviously, babies that were never repaired do not survive, and so that cohort is not in this graph. But for us, it is something that has been very successful and something that we've adopted. Repairing CDH on ECMO is something that is only done at certain institutions, and so one thing is just that to know that we really are the only center in the Pacific Northwest that safely offers this and has a large volume of experience with doing this. We've done it now for about 5 years, and we have very low complication rates with doing it. So the if you end up referring a family to a center that does not repair on ECMO, there is a chance that the baby will not be able to separate from ECMO without a surgical repair. And we've had at least 2 situations in the past 2 years where parents did not know they were at an institution that did not offer repair on ECMO, and then there was a need to transfer them to our institution or withdraw care on ECMO without repair. And so it's just important to know the places that can do that. And in our area, we really are the only center that offers that. The other thing that we have changed oh, sorry.
Yeah. While we cannot alter the fixed hypoplastic component of pulmonary hypertension in our CDH patients, we do have an opportunity to alter the maladaptive and the maldeveloped components of pulmonary hypertension. We have started to monitor and treat pulmonary hypertension earlier than we used to. We now do set echo and lab parameters that we follow that help with treatment decision making. Our pulmonary hypertension team, 2 of whom are pictured here, guide our treatment modalities and balance them with their side effects. We have limited our use of INO to only the most severe patients with hypoxia, despite being on 100% oxygen, and are very diligent now about monitoring RV and LV dysfunction and looking at shunting across the PF4 ASD. We use early vasodilator therapies and titrate them up to effect gradually, and you will see on the next slide a paper that was published sharing that information.
Yeah, we had a recent publication in JAMA Pediatrics about this, and basically the take-home message is just that early prostacyclin therapy at our institution we use treprostinil, but this paper looked at all prostacyclin therapy, was associated with the decreased use and duration of ECMO. And then shifting to looking at protocols, this is a study, a very nice study that came out of Colorado Children's Hospital. And this also was a study looking at the most severe cohort, and with initiation of really aggressive early intervention and protocols, they were able to increase the survival in that cohort. And we really tried to mirror national trends like that. And so these pathways have been developed over the past couple of years, and they've all been developed in a multidisciplinary fashion.
And most recently, we've updated our guidelines based on our experience over the last several years. So we use individual cases that we have reviewed over time and the learnings from other high volume centers to inform these guidelines. We've received an incredible amount of thoughtful feedback from our groups, which have informed these guidelines over time.
And then we have a huge clinic component to our program. And so we run a multidisciplinary clinic that includes pulmonology, cardiology, occupational therapy, and our surgeon team. And we've followed these babies until they turn into toddlers and children and teenagers. And we see quite a high volume. And we also see babies who have been repaired at other institutions and then end up getting their follow-up with us because they relocate here, or we're just the closest center with a long-term follow-up clinic. And so we actually see a lot of patients and had 450 clinic visits in 2022 and a similar amount this year. Because we're licensed in many states, including Montana, Idaho, Alaska, Oregon, California, Hawaii, we're able to offer telehealth visits. And what our goal for families that live in other states, our goal is to support local providers so that we can get them back home to their families and make it convenient for them. And so we offer telehealth support and often can make a lot of progress via telehealth with the support of local providers. And this is just a picture of us doing a telehealth visit. Slide. Oh, sorry. And this is just a picture of a telehealth visit that was part of our feeding clinic. It's hard to make a talk about CDH without having a FIDO slide, so here I have one. I think most people on this phone call know about FIDO. The kind of take-home message from this slide is just that there was an approval in survival in the most severe cohort. The severe cohort was based on ODH LHR measurements, and they saw an approval in survival from 15% to about 40%. One kind of caveat to this total trial is just that it was an international trial, and not all hospitals who treat CDH babies have the same survival rates. And so if you are at an institution where you can get a 40% survival in a severe cohort, it might not make sense to offer FIDO. Or I think where the trend is going to be moving towards offering FIDO actually not to the severe cohort, but to the very severe cohort, because that is probably the risk group that is high enough risk and has a high enough mortality that an intervention like this makes sense. And this is something that we do not currently offer, but as part of the plan as part of our plan developing the fetal center, we plan to offer this. We have some slides just sharing our most current research. And so we do adopt these new protocols, these new algorithms, but we always try to study them. And some of the stuff that we've studied have been questions that we've had for our own cohorts of babies. And we'll use our own institutional data to do papers, but also we use a study group quite frequently. And so these are just some examples of recent presentations that we've done on our own cohort and with the CDH study group. This is a recent presentation that we did at ELSO, just basically showing that we were able to safely do early repairs on ECMO for our babies with a very low to no complication rate. And some more examples of kind of the current work we're doing. And the last thing I just wanted to highlight about research is that we actually really care about how our babies do long term. And so we recently got a grant to look at quality of life in our survivors. And so we will be able to present that data in about 2 years. And this is our center. This is our dream and what we hope to achieve in the next couple of years. And as you can see, it really takes a village to care for these babies and their families. And the building of a center and care for the CDH patient and their families is a lot of work, and it's very fulfilling and very meaningful. But it really couldn't be possible without the contributions of many, 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 many people, including many people on this WebEx. And here are some pictures of our most recent cohort for you to look at. If there are questions, we can answer them now. Yeah.
Yes, you can feel free to raise your hand virtually and we can unmute you if you would like to answer it, if you would like to ask a question instead of putting it in the chat box. I'm also sending out the evaluation. The raising your hand is at the bottom of the screen.
Are you telling me that because I can't see it?
Well, I guess WebEx moved it, but it's at the bottom of the screen by the share. There's a hand up.
You know what I'm going to do is I'm going to stop sharing my screen. There we go. And then I can see the chat box. There you go. All right. Let's see the attendance here as well.
Any questions?
Peter, I just sent you a request to unmute. You can unmute. Oh. Try one more time.
Can you hear me now?
Yeah.
This is Pete Juarez. I'm a respiratory therapist there at Children's. several years ago, I attended a lecture on CDH at our Respiratory Care International Convention, and they talked about the ipsilateral lung seeing a lot of damage. Do you have any comment on that?
I think that's part of the problem is that there seems to be like a mosaic distribution of lung disease in these babies. And so the more diseased lung on the ipsilateral side tends to be much more susceptible to barotrauma and volutrauma. And so when you're thinking about ventilating these babies, it's really, really important to limit the pressures that the lungs are receiving because you're right, the ipsilateral lung or sometimes even parts of that contralateral lung in a mosaic type distribution will receive the majority of that pressure. And so it leads to chronic lung disease for that reason.
We have another question in the chat box. I'm curious why there was an increase of CDH babies in 2022. Do we know why the increase took place?
I don't know why. We've had a steady increase, really over the past 5 years, but in 2022 we had more babies than previously by a significant amount. There is a lot of speculation that it might have to do with laws about termination and that sort of thing, but I don't know. That's only speculation.
There aren't any more questions. I just want to follow up and let you know that there will be a recording that will be finished in a couple weeks. And so by attending, you will go ahead and be sent the recording. And the email, the eval I put in the chat box, but we will also be following up with evaluation sent to your email tomorrow. And we have another CME coming up on December 14th. It's fetal echocardiography, understanding the normal and abnormal fetal heart. And Kenton is going to go ahead and put that flyer in the chat box and you can register. It's December 14th at the same time, 6 o'clock. And I'll check again to make sure there aren't any questions. Okay, Kenton put it in the chat box. Thank you so much, Dr. Stark and Dr. Villamary. That was such a great presentation.
Thank you.
Thank you very much.
Thank you.
There is one more question in the chat if you want to ask that really
Oh,
quick.
I'm sorry.
It just came in. Are we doing any specific marketing to show the lay community our results?
Yes, plus. More to come. The goal is to try and spread the word as much as we can. And we're looking at ways like this and others to kind of share the work that we are doing in trying to increase our volumes, trying to increase the care that we provide to the patients. So yes.
Thank you again for staying late and listening to us.
It was a great presentation. Thank you so much. And we will follow up with the recording once we have that done. So, hold on a second. We have another one. The link to the other presentation appears broken. Let me see, here's one.
Let me, Dawn, this is Kenton. Let me test it one more time because I tested it and it worked. Let me do this one.
Lonnie, I think I also want to believe that, and that may be true.
Okay, give me 1 second and I'll put it in
Okay.
again.
Kenton, I just put in an updated link, which I think should work. So.
Okay. That's funny because it worked a minute ago. I'm not sure.
We'll make sure that we follow up with the flyer too when we send out the eval tomorrow again.
Did you just put it in again, Aaron?
I just posted it once, so. But I think like Dawn said, hopefully that works, but if not, everyone on this call will be getting it tomorrow, most likely in an email. So.
Great,
Thanks
thank
for
you so
confirming,
much.
Tia.
New one works, good. Thank you so much, Dr. Stark and Dr. Millimere. That was a great presentation. Everybody have a wonderful evening.